Well, thank everybody for coming. Good to see such a full house, and hope you are all enjoying your lunch. We're really excited today to have with us Dr. Katie Oldenburg. Dr. Oldenburg is an associate professor at the Francis I. Proctor Foundation in the Department of Epidemiology and Biostatistics at the University of California, San Francisco. She is also the program director for the PhD in Epidemiology and Translational Science. Dr. Oldenburg received her PsyD in Epi with a focus in infectious disease from the Harvard T.H. Chan School of Public Health. And she also holds an MPH from Boston University. We know somebody from Boston University. An infectious disease epidemiologist. Her work focuses primarily on antibiotic-based strategies for prevention of pediatric infectious disease, child mortality, and malnutrition, using randomized controlled designs, which she told Ross and I this morning. She knows a lot about randomized controlled. She's been funded extensively in her career and is currently the PI on 8 studies. There might be more, but she was unsure when I just asked her, but at least 8, funded by NIH and foundations focused on malnutrition and antibiotics and child health. And she also has over 250 peer-reviewed publications in her science. Kind of a lot. So on that note, it's really a pleasure to have you. I'm going to turn it over to you.
Thank you so much, Deborah. Thank you so much for that kind introduction, and thank you all for being here. I'm excited to share a little bit of this work. I'm going to focus on one aspect of my research portfolio, which is azithromycin for prevention of child mortality. I chose this one because I think it's a really interesting story that takes us all the way from efficacy trials, really placebo-controlled efficacy trials, all the way through the development of national guidelines and programmatic implementation of an intervention to public health, in this case, to reduce child mortality. I've been extraordinarily fortunate to work with a really, really large team of a lot of people all over the world who have supported this work, who have led this work. And this is certainly not my work in isolation by any means, and I do not mean to present it as such. I have had the immense fortune of really being on the front row of watching the development of guidelines for this, and it's just been such a fascinating process for me. I wanted to kind of share the background. So to start out, I want to talk about mass drug administration for infectious disease. This intervention is a mass drug administration intervention, and so just to have everyone on the same page about what that means, this is an intervention that is aimed at for administration of preventive chemotherapy for an entire at-risk population. And so this is not about treatment of an individual with a specific infection, but really about administering an intervention to an entire population that's at risk to interrupt or reduce transmission of a pathogen. These are usually campaign-style deliveries. So teams will go out and they'll go door to door to households in a given geographic area. And they will administer the medication, whatever it is, to individuals who are in a given population. Everybody in the population will stratify based on age or something like that. And usually they happen once or twice a year. Not all interventions are really amenable to this style. So it really requires a safe and effective and low-cost drug, typically. Something that is relatively easy to administer. It doesn't have a large side effect profile because monitoring for serious adverse events in a situation like this is very, very challenging. So it really has to be something where the side effect profile is quite low. There's lots of examples in public health, including malaria with seasonal chemo prevention, other neglected tropical diseases, and the one that I'll focus on briefly at the beginning is trachoma, which is where this azithromycin work comes from to begin with. As a trigger warning, I have some eye photos coming up, so it's the only slide that has gross photos, but just to show what trachoma is. So trachoma is an infection of the eye caused by the bacteria Chlamydia trachomatis. It's an ocular-specific strain of chlamydia. And mass azithromycin distribution, door-to-door style to the entire population, age 6 months and over, has been the mainstay intervention for trachoma control for about 25 years now. Is extraordinarily effective. This is some data from a trial that was done in Ethiopia that's showing 2 different treatment groups and then a control group that only had M-line measurement done. And each of these arrows is indicating an MDA, so mass drug administration with azithromycin. And so we see like fairly high prevalence. This is really high, 40 to 50% at baseline. That reduces quite precipitously in the presence of mass drug administration with this azithromycin. And if you compare it to control at the end, if you compare it to the control at the end here, that stayed quite a bit higher than the intervention group. So azithromycin works very, very well for control of trachoma. And it interrupts transmission of the pathogen that causes trachoma, and has led to really precipitous decline in the prevalence of trachoma worldwide. There's only a few hotspots left in the world. Azithromycin is a broad spectrum antibiotic. It's a Z-Pak, and it's used for treatment of all kinds of infections, bacterial infection. And so in the early days of building the evidence for trachoma, for azithromycin for trachoma, a number of studies were done in the context of trachoma, looking at other childhood infections. And so the major causes of infectious mortality in children are diarrhea, malaria, and respiratory infections. And so studies were done looking at the impact of mass drug administration for trachoma on these causes of mortality in children. And in general, we see that there are reductions in diarrhea, there are reductions in respiratory infection, and perhaps some indication of a reduction in malaria prevalence with distribution of azithromycin. Malaria, of course, is not a bacteria. Azithromycin does have some anti-malarial properties. It's the apical plaque in the plasmodium, and is used in multi-therapy in some cases for malaria. But there has been some signal suggesting that mass distribution of azithromycin may have some effects on malaria. And then in the context of a trachoma study, some of my colleagues at the Parker Foundation found that there was a 50% reduction in mortality in Ethiopian children who were in communities that were receiving mass azithromycin distribution compared to a delayed distribution community, or several delayed distribution communities. And this is really a remarkable finding. A 50% relative reduction in mortality is huge. And sort of led to this theorizing that perhaps there may be these beneficial unintended consequences, good ones, for improving the health of children in communities that were receiving azithromycin for trachoma control. Child mortality in sub-Saharan Africa has dropped enormously over the years, and these are outdated data. So the most recent here is from 2015, which is 10 years old now. So we've seen large drops in child mortality across sub-Saharan Africa, but there are some regions that still see really persistently high child mortality. And in this talk, I'll be focusing mostly on the Sahel, which is this region here. Burkina Faso, Niger, Mali, and some parts of northern Nigeria, where we still see extremely high rates of child mortality. So the results of the study from looking at child mortality in the context of trachoma programs led to considerations of design for a trial that was specifically focused on looking at answering the mortality question. So the Ethiopian trial was not focused specifically on mortality. Mortality data were available by a census that was done for the trachoma program. But mortality is a rare endpoint. It's much more difficult to study in many ways than trachoma is. This led to the Mordor study, which was led by Dr. Tom Liepman, Dr. Jeremy Keenan, and colleagues, which was done in 3 countries in sub-Saharan Africa between 2015 and 2017. I joined the Parker Foundation as a postdoc in 2016. So I came in right as the study was ongoing, and I went to Niger for the final study visit. So Mordor was a study that was conducted in 1,500 communities in the 4 countries, which evaluated biannual azithromycin to children aged 1 to 59 months compared to placebo. The reason that they evaluated biannual versus annual azithromycin was based on modeling studies suggesting that biannual distribution may be more beneficial. And this study was conducted over 24 months of follow-up. And I included the mortality rates in children per 1,000 person years. This is per 1,000 person years, not live births. And you can see that the highest mortality rates, as expected, were in Niger. The mortality rates in Mordor were 27.5 deaths per 1,000 person years in children under 5 during the Mordor study. So it's extraordinarily high. So the primary outcome from Mordor was they found a 13.5% reduction in mortality in the communities receiving biannual azithromycin compared to placebo. And this was a statistically significant difference, very strongly significant, statistically significantly difference. In results that were broken out by country, again, Niger had the highest mortality rates, and it also had the largest effect. So this was an 18% relative reduction in child mortality under 5 in communities receiving azithromycin compared to placebo. And there was no statistically significant difference in Malawi or Tanzania, which had lower mortality rates. This led to a lot of hypothesizing that the areas with highest mortality rates may have the most benefit, and that really we should be thinking about targeting an intervention like this to areas with very, very high mortality rates. We also looked at results broken out by age group. So here we have, this is by country and by age group. So overall on the left here, and then in groups from 1 to 5 months, 6 to 11 months, and so on. Again, because the mortality risk in children goes down as they get older. So highest mortality risk during infancy, and then it kind of goes down. And across the board, the most benefit was seen in the youngest children. And so that was really in this 1 to 5 month old group, as well in the 6 to 11 month old groups, which again led to hypothesizing that perhaps targeting the higher mortality groups, higher risk children, would be an effective way to distribute this intervention. We did look at this data in one other way, which is thinking about the absolute number of deaths that are averted rather than just relative reductions. So even though children in the youngest age groups have the highest risk of mortality, there are fewer children in those groups. So if you're thinking about absolute numbers, the data do suggest that treating the entire group is going to avert more deaths in an absolute sense than just targeting them in the smallest groups. So just another data point thinking about the population level. The number one question that I typically get when I'm talking about azithromycin for child mortality is, well, what about antibiotic resistance? And yes, antibiotic distribution, mass distribution of antibiotics typically does select for antimicrobial resistance. This is some data from a systematic review that PhD student at the time, now professor at UCSF led, looking at azithromycin distribution and selection for macrolide resistance in pneumococcus. Pneumococcus is a commensal organism that can become an invasive infection that's often used as a sentinel organism for looking at antimicrobial resistance. And this was a systematic review that was trying to kind of collate all of the data before we started getting results out from Mordor and other studies to look at what happens with antimicrobial resistance. And so in general, what we see following distribution of azithromycin is that the prevalence of macrolide resistance in pneumococcus will go up. And when the selection pressure is removed, when antibiotics are no longer distributed, in general, it goes down. Although you can kind of see that the longer term studies, there just aren't that many of them about kind of what happens long term in communities. I will talk a little bit more about antimicrobial resistance with some other studies. So Mordor led in part to the development of World Health Organization guidelines regarding the use of azithromycin for prevention of child mortality. So several years after the study was published, the WHO came out with these conditional guidelines with a very conditional recommendation for implementation of azithromycin in high mortality settings, which they defined as settings with over 80 deaths per 1,000 live births to children aged 1 to 11 months of age. And I want to note that specifically, that they restricted it to this 1 to 11 month age group. And I'm going to come back to this towards the end of the talk, because Mordor did not look at distribution to 1 to 11 month age children alone. It only looked at the full range, 1 to 59 months. So while we did use a number of subgroups looking as subgroup effects in 1 to 11 month olds, there were no trials at the time these guidelines were developed that was assessing 1 to 11 month old distribution. And since we're talking about most likely infectious causes of disease here, it is not only possible, but probable that older children are transmitting diseases to their younger. So just keep that in mind. I thought this was really fascinating. The reason that they did this was because they were trying to balance the number of doses of antibiotics distributed with benefits for mortality. So they really leaned heavily on those 1 to 11 month subgroup findings and with trying to distribute the minimum number of doses necessary to be effective for preventing the most deaths. These are some data, these are data from Mordor looking at resistance. This is genetic resistance determinants in the gut. And so this is macrolides up here. So this is genetic, not phenotypic determinants, but generally showing that the communities in Mordor that received azithromycin did have a higher increase in genetic resistance determinants for macrolides, as expected. And there was some signal that there may be an increase in beta-lactams, which includes amoxicillin. which is an important finding because amoxicillin is the most commonly used antibiotic for childhood infection in these settings. It is used for everything. And so really beta-lactams are a group that people pay really close attention to in these settings because the loss of amoxicillin for effectiveness would be could be catastrophic. So there were a lot of research questions out the corridor, and I'm going to talk about some of these. So one was replication. So the conditional guideline was really based primarily on one single study. And so a priority was replicating that study in a different place, in a different time, different mortality, that sort of thing. Another key one is implementation. So if we're talking about having guidelines, how do we actually deliver this intervention? We can maximize reach efficiently while we're maintaining effectiveness. A question related to the guidelines is targeting. So can a smaller group of higher risk children be treated and achieve similar effects? That was a high priority question because of the guideline. And then mechanism and adverse events. A really big question when Mordor first came out, really kind of top conversation was, well, why does this work? That's actually a really difficult thing to answer. I'm not going to talk a lot about that today, although I am happy to chat about it later. It's very difficult to study. And then adverse events, primarily the one most people are interested in is antimicrobial resistance. And I will talk about that again briefly. So the first study I'm going to show is the WashU trial. So WashU was in the replication realm. It was really designed specifically as a replication study. This was done in Burkina Faso in Nuna district. We randomized 341 communities, so it's quite a bit smaller than Mordor, 1-to-1 to receive biannual mass azithromycin or placebo. And these communities received 6 rounds of treatment distribution from 2019 to 2023. So that was over a 36-month period. So the distribution period is a year longer than Mordor. We assessed vital status during a door-to-door census every 6 months, which was at the same time that we distributed the antibiotic. This is just a map situating where Nuna is. So Nuna's here in Burkina Faso on the Mali border. It's about 4 hours outside of the capital of Ouagadougou. And then I also wanted to note that, and I won't talk about this at length, but just to note that this area of Burkina Faso and really most of Burkina Faso has undergone a very rapid escalation in an insecurity situation. And so when we started the trial, we did a census prior to the beginning of the trial. We had over 300 communities that were participating in the study. And as you can see here, we had a number of communities in this area here that are shaded in purple that we couldn't continue the study in because of security reasons. There's a big forest right here, and a lot of the perpetrators of the insecurity were in the forest. And so it just wasn't safe for our study staff to work there. So we accounted for this in the design of the trial. We knew this was going to happen, that we would lose clusters, in some cases temporarily. They could be there for one census period, miss one, and then come back in. And so our design was flexible to account for that. But we did lose statistical power because of this. So WashU was 341 clusters randomized. 56 were never measured because of the security issues. So that's actually a fairly large number of clusters to lose in a cluster randomized trial. So we ended up with 285 in the analysis. This was 68,000 children aged 1 to 59 months, and almost 120,000 child years of observation. And we saw over 1,000 deaths. And a little shout out to our data coordinating center at Proctor. There were 8 days between the end of data collection and the study team being unmasked. It was remarkable. One of the just most exciting days of my life was being called into an urgent meeting with the data team, and I knew what they were going to do. And they gave us a presentation with the primary results of the study, and it was really fun. So treatment coverage was high. It was similar between the 2 treatment groups. This is something that we measured for intervention fidelity, but treatment coverage was over 90% for most of the measured periods. Again, I think this is a testament to the astronomical amount of work that our teams did under very, very difficult conditions. And so the primary analysis. So the WashU trial showed an 18% relative reduction in child mortality in communities receiving azithromycin compared to placebo. But I will note that this was not statistically significant at p-value of 0.07. Again, we lost statistical power due to the loss of 50-something communities. And so that confidence interval does cross zero there. So we see a reduction in mortality. I will note that the mortality was lower in these communities than we anticipated when we planned the trial. But there is a 18% reduction, which is very, very similar to the Niger site of Mordor. So on the whole, I would say that, we're cautious in our interpretation, given that this is not technically statistically significant, but given that it's very in line with the results of Mordor, we were really excited about these results and we felt that they were very supportive of what was seen in Mordor. These are results broken out by age. So because of the higher mortality risk in the younger children, and because of the conditional recommendations from the WHO, we repeated that subgroup analysis. Again, I would say that this is a smaller study with lower mortality rates that has reduced power, but we actually found no evidence of an effect in the subgroup of the youngest children. So this is contradictory to Mordor, and shows that really the most of the effect here was in the older children. I don't have a great explanation for that. I know that children in Burkina Faso, when they're younger, they get a lot of other interventions. So it may be that other things are happening for them that's preventing mortality, and there's kind of no additional benefit of azithromycin. But I think the interesting finding here really is that the effects in Shaw specifically was in the older kids. We also looked at AMR and Shaw. So this is genetic macrolide resistance here at baseline in 36 months. And in this study, we found no evidence of a difference in genetic macrolide resistance determinants between azithromycin and placebo communities. In general, the prevalence of genotypic resistance goes down over time, with a couple of exceptions, and on average, there was no difference. I would say that background antibiotic use in Burkina Faso many years later, or not many, but several years later after Mordor is quite a bit higher than we think it was in Niger, although they don't have good data to support that. So one hypothesis is that these kids are actually getting a fair number of antibiotics. They get on average 2 to 3 courses of antibiotics per year. So there may be just enough other antibiotic consumption going on that this additional 1 or 2 doses per year is not really changing things. That's just a hypothesis. I don't know that for sure. So the conclusions for Shaw, so this was published in JAMA in 2024. Results were consistent with the Niger site, but contrary to Mordor, we see no evidence of a stronger effect of azithromycin in subgroups of infants, and we see no evidence of a selection for macrolide resistance, again, contrary to Mordor. So I'm going to talk about implementation briefly and talk about 2 different trials that were, or 1 trial for implementation, then we'll move on to targeting. So the Chaton trial was really designed specifically to think about, how can we best administer and implement this intervention. And so mass drug administration, door-to-door administration is very challenging. It's very logistically challenging. It's quite resource intensive. It's expensive to get out there. And so Chaton was really asking the question, could we integrate azithromycin with an existing health system contact that most children have? And so it was looking at integrating azithromycin into vaccine visits. Vaccine coverage is quite high in Burkina Faso. It is not 100%, and coverage data is not reliable, but we think that vaccine coverage is relatively high. There are 2 ways that vaccines are administered in Burkina. One is that children can come into the health clinic and they'll get their vaccines during vaccine days. And there are also teams that go out once a month into rural communities, and they do vaccine visits there directly in the community. So we used both of those mechanisms to recruit children into the Chaton trial. And so what we did was we administered either a single dose of azithromycin or placebo at the time that they were getting their vaccine. So this is an individually randomized trial comparing single doses of azithromycin to placebo. This was done in 3 regions of Burkina Faso. Infants were enrolled at 5 to 12 weeks of age, and we assessed mortality at 6 months of age. This study was also published in 2024, and this was published in the New England Journal. So we enrolled almost 33,000 children. We enrolled about 210 children per week over 156 weeks. And then we had 96% of the children that were enrolled contributed to the analysis. This was 15,000, almost 16,000 child years, and 157 deaths. And I don't know how they did it. 2 days between the end of data collection and study team unmasking. It was, again, very, very remarkable. Enrollment type visits. So we had a mix of either community visits or clinic visits. So most of these were in the context of vaccination, although we had a community child health day here, which was about 1/3 of them, which was outreach for other child health activities, and we enrolled as part of that to increase our enrollment. So primary analysis, we found no evidence of a reduction in mortality in children who were receiving azithromycin compared to placebo when administered at the individual level. So this is not a cluster randomized trial. We're not doing mass distribution. So this was consistent with a hazard ratio of 1.1, and it was not a statistically significant difference. So conclusions here were that individual level of administration does not reduce mortality in infants in Burkina Faso. And we think it may provide some insight into the mechanism. So again, we're really targeting infectious causes of mortality with an intervention like azithromycin. And so if it's working at the community level and it's not working at the individual level, there may be something about treating everybody at the same time that is interrupting or reducing transmission of pathogens that can give us, and this can give us some insight into mechanism. So targeting treatment. So the third area that I'm going to talk about is can we target treatments? And we talked about this a little bit in terms of age with Chaton, with that was just in infants. And I'm going to show two other studies, one finished study and a couple of ongoing studies that are getting at this question of targeting. So again, why might we want to target? This is some data that's kind of comparing data for microbial resistance. Again, this is pneumococcal resistance, phenotypic pneumococcal resistance in the context of mortality, and then comparing it to what we see for trachoma. So trachoma treats the entire age range, 6 months of age up with no upper age limit. Everybody in a community gets azithromycin for trachoma control. Whereas in the mortality programs, we're only focusing on children under the age of 5. So the proportion of the community that's receiving an antibiotic is quite a bit lower. And that leads to a hypothesis that we may select for less resistance because we're administering fewer doses. And that seems to be the case in the data, that we have this overall is lower, kind of putting everything on the same time scale. The trachoma program does not get nearly the attention that the child mortality program does, but they've distributed over 1 billion doses of azithromycin for trachoma control. So there's a lot of azithromycin out there for trachoma. So the theory is that if we could limit the amount of antimicrobial resistance selection, but maintain efficacy or effectiveness, and maintain that mortality benefit, that would be a good thing. And that's really what the WHO is going for with those guidelines. So some ideas for targeting strategies, we can look at age group, we can look at mortality risk, and there may be other targeting strategies. So the Avenir trial was a study that was done in Niger. So this study was looking at treating, so this included the same groups as Mordor, which is mortality. This is children that are 1 to 5 months of age, 1 to 59 months of age, receiving azithromycin or placebo, but it included a third arm, which was looking at administering azithromycin only to the 1 to 11 month age group. And so these are the primary results from Avenir, which was led again by Kieran O'Brien at Proctor, published in the New England Journal in 2024. That's looking at the effect of mortality in children 1 to 59 months of age here. So this is looking at azithromycin to the entire age range versus placebo. And we see about a 14% reduction, a statistically significant difference. This again is a replication of Mordor, exactly the same question. But what Avenir additionally includes is this 1 to 11 month age group. So this is looking at mortality in infants aged 1 to 11 months of age receiving azithromycin compared to placebo. And there's no statistically significant difference when you're looking only at that limited age group versus the 1 to 59 month age group. And so this is directly addressing that WHO guideline. This is directly comparing 1 to 11 month olds getting azithromycin compared to placebo and finds no evidence of a difference. So this is really supportive of the fact that there is something about the community distribution that's required and that these children most likely have siblings. These siblings are probably transmitting pathogens back to their younger siblings, and only treating the 1 to 11 month olds is not going to work. And so this is relevant when we talk about policy because this is a really big discussion point. And so really what this showed us was that we need to be thinking about this entire 1 to 59 month age range. In SHA, we did a subgroup analysis by acute malnutrition to start thinking about whether higher risk groups, like for example, by malnutrition status, could be an effective strategy. Again, this has not been looked at independently and when you're not treating the entire group. So malnutrition in all of its forms is a risk factor for mortality. again, we see, overall mortality is reducing, but we have very, very high risk of mortality among children with malnutrition. And so we took advantage of the SHA trial and we measured mid-upper arm circumference, which is a common measure of wasting in children. And this is commonly measured routinely by community health workers and screening programs. And so we did this in SHA. We measured MEOC on every one of the children at each study visit. And we used a common cutoff of 12.5 centimeters to indicate global acute malnutrition. And as expected, we saw quite a bit higher mortality rates, so 26.3 deaths per 1,000 person years in children with global acute malnutrition compared to 8 in children without acute malnutrition. And so this 26.3 deaths is quite similar to what was found overall in Niger and Mordor. There's a very high mortality rate in these kids. And in general, we saw some evidence that when we look at the subgroup analysis, that there may be a stronger effect of azithromycin in children with global acute malnutrition who are on the right compared to children without global acute malnutrition. So this was some signal that perhaps there is, these kids do have higher mortality. They may be benefiting more than kids without acute malnutrition. This is just looking at it on the incidence rate ratio and incidence rate difference scales, and very similar findings. So the limitations, of course, of the subgroup analysis are that we didn't look at we didn't only look at the kids with acute malnutrition. We're only treating the entire group. So we have the same problem where we don't know if the kids with acute malnutrition are interacting with kids without acute malnutrition, and there may be some additional benefit, some spillover effect from those kids, most likely. We do have sample size and power limitations inherent to most subgroup analyses. And there's lots of other ways to think about malnutrition. MEOC is not the only way, but we didn't have the resources. It's very difficult to measure weight and height in the field at that scale, so we weren't able to measure other forms of malnutrition. So I'll talk really briefly about next steps for targeting 2 relevant studies that are ongoing now in my research group. The first is the AMOR trial, which is funded by the NICHD, which is looking at azithromycin versus amoxicillin, which is standard of care, versus placebo for children with severe acute malnutrition. So these are children with very low MEOC and or very low weight for height Z-score. This is a trial that's about a third of the way done enrolling. It's being done in Burkina Faso. And then a new study, we just got an R1 over the summer to do a study looking at azithromycin in infants at risk of poor growth and development. This is defined by WHO guidelines, which is focused on kind of identifying the subgroup of children who are at the highest risk of wasting, developing wasting during infancy. So this study will get going in the spring and is also funded by the NICHD. I'm not really going to talk about mechanism much in the interest of time, but the overall what has been looked at so far has been infections. And in general, we see a signal that there's reduced enteric infections, reduced malaria, and reduced respiratory tract infections. But in general, we don't see an effect on nutritional status or weight gain. One of the hypotheses has been kind of the chicken hypothesis, that we treat our chickens with antibiotics so they plump up. And so maybe that's happening to our kids too, and that doesn't seem to be happening. So we don't see any signal that there's an effect of azithromycin on weight gain. And then cause-specific mortality is really in line with this as well. These are verbal autopsy results from Mordor, and we had very similar findings in SHA, where we see a reduction in infectious mortality. This is SHA. And then just in the interest of time, so I want to talk about kind of what happened after all of this. So we have a number of trials now that have been done, and now we're really moving into programmatic scale-up. So after the Mordor trial was completed, really while Avenir and SHA were still ongoing, there was a network called REACH, which I don't remember what that stands for, which was established to bring together kind of all of the stakeholders that were involved in this azithromycin work, specifically to talk about how do we translate the results from these trials into policy. It was really independent of WHO. WHO has not released updated guidelines yet. I expect they will in the next couple of years, but it hasn't happened yet. And so it was really like, taking together all of this evidence. How do we implement the intervention? How do we monitor it for ongoing effectiveness? And as well as how do we monitor antimicrobial resistance? And so as of 2025, Mali, Niger, and Nigeria have azithromycin implementation programs, and Burkina Faso's was approved in 2025. We expect that the first doses programmatically will be distributed in Burkina Faso in 2026. And this happened really fast. So 17 million doses of azithromycin were distributed for child survival as part of public health programs by the end of 2025. So I'll show a kind of timeline at the end, but this has all happened in the space of my public health career, which really started when I graduated with my MPH in 2009 up until now. And I want to talk a little bit about the policy development process in Burkina Faso, because for me, that was really fascinating. As someone who is, I'm an epidemiologist, I run trials. I'm not really involved in the policy development phase, but I got kind of a front seat view to this because we had to put together a lot of presentations, work really closely with our colleagues in Burkina Faso to kind of talk about the evidence and help kind of make sure the evidence was understood in the translation to policy. So that was really a fascinating process for me. So we had presentations by academic teams. We had meetings across stakeholders, including the implementation organizations, funders, ministry. And we had a lot of lessons learned sharing from other settings that were a few steps ahead of Burkina Faso in terms of their implementation program. And I think the things that the policymakers were especially focused on were the discrepancy between the WHO guidelines focusing on that 1 to 11 month age group and the trial data, which really supported implementation 1 to 59 month age groups. And azithromycin being approved for programmatically in Burkina Faso almost got blasted out of the water because of this. So it almost got completely shut down because there was this discrepancy where the WHO was saying this, you're saying that, who's right? And that was an interesting process to navigate with, thinking through what the implications of that conditional guideline meant in terms of actual implementation at scale. And something that I didn't anticipate happening. And so the other one that people, of course, talk a lot about is antimicrobial resistance monitoring, how to do that and how to ensure that we're not creating a situation where we have infections that can't be treated. These are both, but especially the second one is really a very active area of work now. There's a lot of capacity building going on in the region to make sure that the laboratories have the capacity to monitor antimicrobial resistance. And there's a lot of, for one of the questions that's outstanding in my mind is that, so we haven't seen any signal that azithromycin is not working for mortality anymore, but are there earlier signals that we should be monitoring that perhaps the antibiotics are becoming less effective? And I would say that those data really don't exist. At what point do the antibiotics become kind of less effective? So future directions. So again, we have the 2 ongoing studies targeting high-risk groups, Vivant and more. And then there are a lot of implementation and scale-up questions. So one of the questions that I think will be asked in Burkina, and our group is doing some monitoring, working with the ministry and others to do monitoring and evaluation of the scale up in Burkina. So a question that I think will be answered by Burkina is when to stop. So we kind of have guidelines on when to start, but we don't really have guidelines on when to off-road this intervention. So I think that's a key research question from an implementation perspective. Another one that's very active is integration of multiple platforms. So if we're already going out door to door, there are other programs that are going out door to door. Can we integrate them in some way so that we're not duplicating efforts? We're not going to the same households multiple times and spending that money multiple times to see the same kids. And again, ongoing surveillance for AMR and for mortality to ensure that this is continuing to be effective. I think that will also inform the when to stop and that we're not selecting for very high rates of AMR. There's a lot of debate about the kind of immediate mortality benefit versus hypothetical selection for AMR that I'm happy to talk about afterwards. It's very interesting. But on the whole, we've had multiple studies suggesting this is a very highly effective intervention. It's at scale now in many countries, and really has just been a fascinating story to watch unfold. And so just to wrap up, this is a little bit of a timeline, just putting this all together. So again, like I mentioned, the original Ethiopian study showing that 50% reduction was published in 2009. This is the year I joined the Proctor Foundation as a study coordinator. I went to Ethiopia in 2011, supporting some of the trachoma work. The Mortar trial was conducted between 2014 and 2017. And then in 2019 was published, showing that 13.5% reduction in child mortality. SHA and Avenir were conducted between 2020 and 2023. They were both published in 2024. And then as of 2025, 17 million doses are delivered programmatically. And we anticipate that this year we'll have the first programmatic dose delivered in Burkina Faso. And then thinking out on the kind of 20-year horizon, right now we're anticipating results for Amor and Vivant to come out in 2028, 2029. So this is the story of azithromycin for child mortality. And thank you so much for your attention and your time.
Questions?
A great presentation. Thank you. Unfortunately, the two questions I have are the two things that you said. Maybe talking about them later.
I can talk now.
The first one, what you mentioned about AMR, I'm actually really interested exactly what you said, especially given that it seems like from the trial, azithromycin works at a community level, not a individual level, which to me screams then we really need to worry about AMR.
Yeah.
Are there at least some modeling studies looking at immediate benefits from mortality compared to future expectations on AMR?
That's a good question. I don't think there are any. So the studies have generally found that the effects on mortality happen in the short term. So it's, within 3 months or so. And then after 3 months, we don't see much additional mortality benefit. In terms of the long term, the modeling studies, there is an entire working group that's doing the modeling studies now that I haven't seen results from, but I think they're working on that. So, I think if we were to extrapolate from, I think this is why the when to stop question is so important, because if we're extrapolating from the trachoma programs, in general, the data suggests that when you stop distribution, eventually it's going to return to baseline levels, or pretty close to baseline levels, which is it's reassuring, but obviously we want to see it in the child mortality context too. So I think the working group is working on that now, and I think that's a kind of central part of ongoing implementation is really being very careful about monitoring for AMR and making sure that every program, so each program in each country has an AMR monitoring component to it, and that was kind of part of the guideline development was that each country has to have that plan in place. So those data will come out. I haven't seen anything much past 36 months or so of monitoring, but some of that's just time. But I think it's a key question.
The second one on mechanism, and maybe you don't know the answer for this one yet, but it was interesting to me that you mentioned anti-malarial effect as maybe one of the ways the mechanism is working. As far as I remember, it's been a long time, but when do you know what are the type of mosquitoes that actually exist in Niger? Because from Sudan, when I described azithromycin for falciparum, it doesn't really work. It's not a first line, so it doesn't really affect malarial transmission. Yeah, but maybe they have a different mosquito. And
it is falciparum.
Okay,
so it's like 99.9% falciparum. This is total hypothesis. My guess is that we've looked at malaria both in mass drug administration and in individually randomized trials, and we don't see any effect at all in the individually randomized trials. So my wonder, and I know that azithromycin is used as part of like IPTP and other like combined regimens, and I know it has some effect on the apocoplast in vitro. So my best guess is that it may be something similar, that when you're distributing it to everybody at the same time, there's some short-term signal. It doesn't persist at all, but like some short-term signal where you're interrupting transmission to some degree. It's not enough that it could be first-line treatment, but it could be enough of an interruption at the population level that you see a signal that you don't see at the individual level. So that's my best guess. It's a hypothesis. Thank you.
Katie, thank you for being here, and a great presentation, really interesting work. I had several questions, but I'll just ask one and then I'll come back around if there's time. I was wondering about, so think about a hypothetical school of public health that's creating a new public health curriculum and training program. If you think about that, sort of dipping your toe in the policy translation world, what are the skill sets either you would have liked to have had or someone on your team would have liked to have had that you would advise us on as we kind of rebuild and enhance some of our curriculum?
That's such a good question. I think where I felt like I fell really short was, as a sort of classically trained epidemiologist, very much on the efficacy trial side of things. I learned a lot working with my implementation science colleagues as we kind of got closer to policy development, kind of guideline development. I wish I had some understanding of how policy is made. And really kind of what are the data points? I think this is important for people who are doing efficacy trials, because if we didn't collect the data during the trial, we can't show it to the ministry when they're asking for the data. So, I think that getting people involved earlier with implementation science expertise would have been really helpful in terms of, there were costing data we just didn't have, and things like that I think would have been really useful. So I think that in my own training, I'm not sure that when I did my MPH, implementation science I don't recall that being something that we really talked about a whole lot back then. And so I kind of wish that, I think as part of a breadth of curriculum, that would be a really important thing to have, like at least a foundations of class that I think would have really benefited me in particular as we kind of navigate through this, and thinking about health policy and that kind of thing and how policy is developed. I think that was, this was, a bit of trial by fire in terms of like, we're here, this is happening. We need to figure it out. And, I do have colleagues that I worked with who have expertise in those areas. But for me personally, I think when I'm thinking about designing trials now, I'm thinking about it from a very different lens than when I was thinking about SHA when we were designing that trial.
Yeah, and some of that's maybe thinking about some of those things earlier in the study than,
Exactly.
than as an afterthought, right?
Exactly.
Yeah, that's great. Thank you.
I had a question about the climate in which you were working. What is the public trust in science there? And how did you navigate when the WHO guidelines differed from the trial guidelines? And I'm thinking of it in terms of vaccine policy here and the correlations. Maybe we have lessons learned.
That's such an interesting question. I think SHA started right before COVID hit. And there are two things in SHA in particular that we experienced. One was that in our first round of treatment pre-COVID, we had a lot of children whose caregivers were saying that they were allergic to azithromycin, which is very unlikely. Macrolide allergies are pretty rare. From all of our experience with trachoma, it's really, really uncommon. And so we had, it wasn't a huge number, but it was in the hundreds. And so we were like, something weird going on. And so we looked into it, and it was actually side effects from seasonal malaria chemoprevention, which does have a pretty strong gastrointestinal side effect. So it makes kids feel kind of bad. So I think what we were seeing was caregivers that were thinking that this was SMC, not it was, the same intervention. And so that they were saying their child was allergic because they'd had a negative experience with SMC. And that wasn't so much a public trust thing as more of like a kind of something that we found from another intervention. SHA was done in Nuna, where my partners there have run an HDSS in Nuna since 1992. And so they are locals. There's an extraordinary amount of trust. There's very careful community advisory boards. There's, we work, it's a very deliberate process, I think, for getting community buy-in and making sure that community leaders know, of course, what's happening. It's not just the people who are in the government and the health facilities, but it's actual people who live in the communities. And so a lot of kind of pre-work went into that before we started the trial, which I think helps a lot. And also there's a lot of trust with the organization we're working with. After COVID started, we saw a little bit more mistrust because they thought we were testing a COVID vaccine. And so that was very interesting, especially given that the communities had gone through one round of treatment already. And so that we handled with, again, kind of messaging, communication, trying to make sure that it was clear what we were doing, what we're studying, and why, and that it really had nothing to do with COVID. But there was a misperception in some communities. We saw a large number of people declining to participate, which was unexpected. In general, mothers have been really, really receptive to, like in Chaton, they'd come back and ask for more azithromycin. So it was really surprising to see a large number of declines. But when we looked into it, it was because they thought we were doing a COVID study.
So I have two hopefully short questions. The first of which is in the first Mordor study, the 1,500 or so. Was the N in each country the same?
Yes, it was slightly larger in Niger and Malawi and slightly smaller in Haiti.
Okay. So I wondered if the confidence interval was a product of difference in sample size or difference in variance, but it sounds like difference apparent?
I think so, yeah, and the mortality rates were a lot lower in Tanzania and Malawi, so I think that, the number of outcomes was smaller, so I think it's a combination. Tanzania was the smallest in terms of number of communities. I think they were about 300, and they also had the lowest mortality rate, so.
And the second question is more like the when you stop question.
Yeah.
I don't know this area. I've done a lot of work in Nigeria. So I don't know what the right term is, but it's the ubiquity of the pathogen that or these pathogens that requires to persist in these things, because in other parts of where you're working, they don't have the same amount of mortality. Is that a product of WashU? Is that a product of better systems?
Right.
And while we're dumping, it seems like a lot of medications, which are prophylactic for some period of time, they're not the structural things that you need to have the long-term public health benefit.
Right.
So do you have insights into that? Is it a chicken and an egg situation?
Yeah, that's a good question. I think, I do think that there are probably most of the mortality benefit reductions that we're seeing at scale are due to development and improvements in WashU, and it's strikingly similar to trachoma, where there are a lot of areas where trachoma is declining by itself. I think with development and with access to clean water and things like that. And so we actually just finished a study in Niger, which was really looking at the when to stop question for azithromycin for trachoma, because theoretically, in areas that have very kind of lower levels of trachoma, chlamydia is probably circulating at a level that's so low that it's not actually going to propagate and create an epidemic. And so we did a trial where we were studying whether or not we could stop mass distribution of azithromycin for trachoma in Niger. Those results will be out this year sometime. And essentially found that there's no difference between communities that stopped azithromycin distribution versus continued azithromycin distribution over a 3-year period in areas that had low baseline levels of trachoma. So, and I think that a lot of that is attributable in the trachoma world to development, to improve WashU, that kind of thing. And I think that that's kind of I don't think that anyone wants to do azithromycin distributions in the long term. And I think that the risk of antimicrobial resistance means that there does need to be some kind of off-road or off-ramp. And so my guess is that that we're seeing reductions in mortality because improved vaccination coverage and improved healthcare access. And Niger, for example, has an initiative where they are working on ensuring that every family has a health facility within 5 kilometers of the home, which is huge. We see huge gradients between kind of the distance decay gradient between how far someone lives from a health facility and mortality rates. We see it in Burkina, we've seen it in Niger. And so I think those types of interventions are like the expensive long-term ones that are going to, be persistently effective. And that is azithromycin is kind of a Band-Aid, in my own opinion. But yeah, I think, and I think that that's really why the monitoring component of the scale up is so important. I think my personal opinion is that there are mass distribution programs where the effectiveness hasn't been evaluated in a very long time. I'm thinking of vitamin A, where I'm not sure that vitamin A distributions actually reduce mortality because we haven't studied it in decades. But it doesn't have the same kind of trade-offs with it's very expensive. It's a whole different beast. But I think that because of the AMR component with azithromycin, it's important to have that balance. So I suspect we'll know more in Burkina Faso in the next couple of years. And Burkina is very, very close to not meeting guidelines for azithromycin. So I think it's going to be a short-lived program.
So I totally agree with you on the vitamin.
Okay, good.
I think we're over vitamin as it is. But my question is related to, and I know the answer to this with regards to the large trials, which is you probably didn't have an opportunity to look at EED, environmental enteropathy. Will you in the future trial?
We did some microbiome work. We are collecting a lot more samples in our individually randomized trials, which again are a little different because it's not mass distribution. We didn't look at EED specifically. We did look at microbiome perturbations in azithromycin versus placebo communities. And, generally we see this in individually randomized trials and the community randomized trials see that diversity in the gut microbiome declines and things like that. I would say that we haven't done a lot more than that. Like it's kind of where it is that the gut microbiome diversity is lower in kids who are getting azithromycin, which makes sense. And some signal that it normalizes too, and when it's been 6 months since they got their last dose, that it's kind of goes back to baseline. One of the questions we'll be looking at in BBONT, which is a very little baby study, is whether those perturbations persist. So we expect them in the short term, but with a very young infant who doesn't have a mature microbiome, we don't know if that's going to kind of persist into later childhood. So we'll have a cohort of kids in that study that are followed for 3 years, up till 3 years of age, to look at microbiome changes over time. So I think we can look at the EED questions and that sort of thing in those samples.
Makes sense in terms of the no weight gain.
Yes.
I think we're out of time, but I want to thank you very much for this.
Thank you so much.